I am Enrico Agabiti Rosei. I am Professor of Medicine at the University of Brescia and the immediate past President of the European Society of Hypertension. We are here in Milan at the 29th meeting of the European Society of Hypertension, which is dedicated, of course, to the assessment of diagnostic therapeutic approach in order to reduce the risk related to hypertension. In fact, hypertension still represents the most important cause for fatal events worldwide, both in high-income countries as well as in developing countries. This is despite the enormous progress in the knowledge related to the excellent scientific research in this field, and also to the availability of several effective and well-tolerated drugs. In fact, only a minority of patients with hypertension are now properly treated. Most of the patients do not know to be hypertensive. In addition, a big problem is also the poor adherence to treatment in the long term, the therapeutic inertia by the doctors, as well as the problems related to the fact that sometimes treatment is too much complicated and there is a modest use of combination treatment which is needed in the majority of patients. The recent European guidelines indicate that at least 5 classes of antihypertensive drugs are suitable for initiation and continuation of treatments. They include ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, beta blockers, and diuretics. And they are indicated because they have been successfully used in large randomized clinical trials that have demonstrated their efficacy in reducing blood pressure and in preventing cardiovascular events. In fact, all these drugs have been demonstrated to be able to reduce major cardiovascular events, cardiovascular mortality, also total mortality, reduction in coronary event, in heart failure, in stroke. And meta-analysis have calculated that for a decrease of 10 millimeters mercury systolic blood pressure and 5 millimeters mercury diastolic blood pressure, there is a reduction in stroke after 5 years of about 40%, a reduction in coronary heart disease for about 20-25%, reduction in mortality around 20%. So these drugs may be considered similar in terms of prevention of cardiovascular events for the same reduction of blood pressure, which is the most important goal. However, they may differ each other for a greater or less effect to some specific endpoints. For instance, RAS blockers or diuretics are more effective in preventing heart failure. Beta blockers may be less effective in preventing stroke. Calcium antagonists may be more effective in preventing stroke. However, there is not a uniform paradigm, but this suggests that some drugs may be used preferentially in some specific patients who have additional risk factors or associated diseases, or also complications of the disease. For instance, as I said, RAS blockers are particularly effective in patients with hypertension and heart failure, in patients with hypertension and previous myocardial infarction, in patients with diabetes, in patients with nephropathy, with proteinuria, and so on. This is just an example. However, considering the problem of poor adherence to long-term treatment of hypertension, The guidelines indicate for the majority of hypertensive patients an initiation of treatment with a combination of two drugs. This because it permits a better blood pressure control, a steeper dose response curve, and a better adherence, probably because of this positive effect on blood pressure, and in the long term better control of blood pressure and also reduction of cardiovascular events, as it has been demonstrated by several observational studies. And the guidelines suggest a sort of simplified algorithm indicating a combination, an initial treatment with a combination of a RAS blocker plus either a calcium antagonist or a diuretic. This may be effective in a large percentage of patients, and the preferential use of calcium antagonists may be for patients with metabolic disorder, for instance, or patients with vascular disease. The preferential use of diuretic in combination, for instance, for patients with heart failure, for patients who are elderly patients above 80 years of age, because these combinations be successfully used in one important study, the HIVET study, and so on. If two drugs are not effective in reducing enough blood pressure, in reaching a blood pressure goal, then three drugs should be used in combination: RAS blocker, calcium channel blockers, plus a diuretic. If this is also ineffective in obtaining optimal reduction of blood pressure, these patients can be called resistant to hypertension and should be given an additional drug that may be an anti-aldosterone drug, such as spironolactone, as suggested by the pathway study, or a beta blocker or an alpha blocker. Beta blockers can be used even from the beginning, particularly when there are specific indications to their use, as in patients with previous myocardial infarction, patients with heart failure, patients with angina pectoris. And this should be part of the combination in the presence of this complication of hypertension. We have talked about the threshold and target for treatment. The threshold for treatment, according to European guidelines, is for patients with a systolic blood pressure of 140 millimeters of mercury and diastolic blood pressure of 90 millimeters of mercury. And the first objective of treatment is to reduce blood pressure below this value. However, recent trials, recent meta-analysis of previous trials have indicated that the reduction of blood pressure should be up to 130 millimeters of mercury, or even below 130, up to 120 millimeters mercury of systolic blood pressure, if this treatment is well tolerated. It is known now that if you reduce more blood pressure, you have some advantage in terms of prevention of cardiovascular events. However, there is also the risk of increasing side effects that may be a cause of withdrawal or treatment. So the doctor should be very careful in balancing the possible effects in terms of prevention of events and the risk of side effects that may may cause the interruption of treatment. And therefore, the final decision on how to treat patients with a combination of drugs to which blood pressure target is delegated to the single doctor. Certainly, some patients who do not have elevated blood pressure but at borderline values often do not need to start with a combination. but they may initiate treatment with monotherapy, and the same may be true for patients, for elderly patients, particularly the frail, institutionalized elderly patients. In fact, in these patients, for those who are fit, independent, in good health, good physical performance, we may reduce blood pressure to a range between 130 and 140 millimeters of mercury systolic blood pressure. But we should be particularly careful in patients who are frail, who have some cognitive dysfunction, who are dependent from a caregiver. In this case, blood pressure should not be reduced too much, and the balance between efficacy and cost in terms of side effects should be carefully evaluated. Which may be the future for treatment. As I said before, we have now several effective and well-tolerated drugs that in combination may permit the control of blood pressure in the vast majority of patients. But for about 5% of patients, the control of blood pressure is particularly difficult because of advanced organ damage, particularly of the arteriosclerotic damage of arteries, and several new therapeutic approach are now being evaluated, including the use of some device, for instance, the procedure of renal denervation, or even the baroreceptor stimulation. Particularly with renal denervation, several studies, several trials are ongoing, and we think that in the next 1-2 years we may have enough data from these trials in order to assess what may be the usefulness of this new approach.